Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman. My professors, dear colleagues, my case is actually much more simple than the previous marvelous case by Dr. Amr. It's actually more related to the first case by Dr. Shazia, which I like it very much, and I hope we can apply what she's showed us on such a case. It's for a 66 years old man, diabetic hypertensive, dyslipidemic, presented in another hospital with acute pulmonary edema and non-STEMI 2 weeks ago, managed there conservatively, and then he presented to us by progressive dyspnea with mild effort at home. He's in sinus rhythm with a poor R wave progression in the precordial leads without any ST deviations. On his presentation to us, he has still mildly elevated troponin and significantly elevated PNP enzyme with ejection fraction 45% and significant antroepical hypokinesia. He also have some or mild CKD and uncontrolled glycemic state. This is his angio. As you see, a very large left main with a eccentric bulky plug in the mid and distal segments of the left main, extending to the ostial LED as well, with diffuse disease thereafter in the LED and possible significant mid lesions. The CX is free from a disease, at least angiographically, especially the ostium appears here is free, and the lateral view shows the diffuse disease in the LED with the ostial and the mid lesions, and still the CX is free of disease. The RCA is definitely angiographically without significant stenosis. So actually I thought I feel better to justify the clinical significance of such lesions, since I don't have a very critical lesions on angiography. I did a QFR, so it showed us for the left main LED 0.68 and for the left main CX 0.56. I did an IVUS as well, and as you see in the mid LED, very diffuse disease with multiple concentric plaque, fibrotic actually, with some calcification, no concentric calcification, but in some parts significant arc of calcification up to 270, as in this segment. As you move proximally, the diffuse disease increased, and as you see in the ostial LED, very fibrotic, calcific, very eccentric lesion, and it's extending to the left main, which you will see now with a very bulky, purely eccentric, very fibrotic plaque, as you see. The ostium and the proximal part of the left main is completely free from disease, as you see here. That's at the ostial and proximal segment of this huge, about 6 millimeter, not less than 6 millimeter left main. The CX is diffusely diseased with some calcium at the ostium, but with a good MLA, and then you go to the left main lesion. So to brief up...
Can we stop here?
Yes, we can.
Yeah. Do you have the in general, activity you're doing there, you have evidence from the morphology and you have evidence from the physiology. I know Ziad Ali in the last 2 days, he has what's known as MLD max. Did you heard about this?
What?
MLD max is a morphology, lesion, length, diameter, and then with that it will have also expansion and position conditions. He said it could be done by taking the CT criteria or the angio criteria, or he can make it during the procedures to know which length, which morphology, which size of the stents. He made this. This is I like this way. In your practice, Sherif now showing us physiology, which is evidence, but morphology, there is nothing in the left main. How can you do? Are you going to stent left main LAD, depending on physiology or depending on morphology? You understand my question? You have morphology, but we don't have physiology, or the reverse. Habib.
I mean, the morphology and the physiology are in favor of a significant lesion of a
LAD.
LAD.
Yes, I'm speaking about left main. Are you going to cover the left main with this part, or just showing precise stenting, or what are you going to do?
It's impossible to have precise stenting in this kind of lesion because the lesion of the ostial LAD is the lesion that extends to the left main.
Yeah.
And if we stent LAD left main, the stent should not be landed at that plaque, which is approximately 40 to 50%.
But usually are thinking, there is a plaque in the LAD, mostly without the left main as well. This is what you think. But if you don't prove it...
It's not the case here.
I mean in general.
It's the same plaque, and I think we should stent from the ostium of the left main up to which is near normal segment of the mid LAD.
The mid, okay.
Yeah. Actually, Dr. Habib, you as if you were attending the case with me, but I did just what you said because I could not find a free or a burden without a 50% at least plaque burden throughout the length, starting from the mid left main up till the mid LAD. So no free plaque area here, and I can show you. I can brief up the IVUS, as you see here. Very significant calcific mid lesion in the mid LAD, and here a highly eccentric plaque in the ostial LAD, which is also calcific, and it's, as I show you in the pullback of the IVUS run, it's completely continuous or extending to this very bulky, as you see, from 3 o'clock to 9 o'clock, very bulky plaque in the left main. I could not ignore it. I know that it's not causing about 50% stenosis or 60%, but in this huge left main, I could not ignore it at all. So that's why this is, as you see, the real healthy ostial and proximal of the left main, completely free from a disease. And also, it's very important in the context of this case, the ostial of the CX. The ostial of the CX is not free of the disease, as you see, with some calcium, but with a good MLA. So this is not significant. And although it was significant by FFR. And this is another point of discussion. Anyway, actually I spent a lot of time in preparation of the LAD and the left main, multiple good preparation with large NC balloons at a high pressure. And then I started with an ostial crossover, ostial left main till the proximal LAD with a large 4.530 drug-eluting stent, and thanks to the IVUS, which assured me about the size of the proximal LED. It's not less than 4.5 actually. And this is, Anjo showed that we need another stent in the mid LED. And we did it here. And then it's time for pot. Positioning the pot is very important, as you know. And we used a 5 millimeter 12 balloon in this huge left main. And this is after the pot. Here, distal recrossing, if we can. The most distal strut that we can be able to catch is better. And here is the recommended way of removing the jailed wire. Getting up your guiding up in the aorta to avoid injury to the stent. And then, as usual, opening the struts to the CX. And then doing optimization. And here, actually, I was very helped by the IVUS. 4 millimeter balloons at a high pressure was not enough, actually, because when I checked by the IVUS, I turned to have a 4.5 balloon again to get better optimization. And here again, more optimization. And then kissing with adequately sized NC balloon. I didn't go to a very high pressure in the CX, but I did make a kiss with the 3.5 in the CX. And this is the final pot with 5.5, the largest NC balloon we have in the CAS lab. So it's not easy to find such a size in our CAS lab. But that's the final angiographic result. As you see, hazy in the ostium of the CX, but still it doesn't appear to have significant stenosis. And what do you think? You leave such a CX, or anyone would like to stent the CX in this?
Already you have in physiology.
Yes.
That is it's significant.
So this is the right answer, I believe. Since we have a physiology and as well and IVUS on the table, we should use it to the maximum. But if we don't have it, actually I would also leave such an ostial CX.
So my question to you, if the angle here is less than 70, and you already have proved decrease FFR in both vessels, are you going to do DK crush, or you are going to do also tap as you are doing?
I believe here it's, for me, I would have put a tap. Actually, much easier.
So you don't respect the angle?
Sorry?
You don't respect the angle?
No, the angle.
Although the evidence of the DK crush in the left main is more than the tap if you have a short angle.
Yeah, but if you...
Sorry, I saw that you're laughing. No. You're United States doing DK crush, or you're the opposite of the Japanese? What you're doing in United States?
I mean, what if we have a third option? You DEB it and that's it. Just run away.
Okay.
I mean, the circ has a big angle here. You have a good flow. You know that the LAD left main is a diffuse disease. If you put a wire now with an IFR, you might have an IFR of, not significant, but pretty low. So you're
But
happy.
here is significant already from the beginning.
It is significant.
But I didn't make it with the kiss, remember. So, I mean, it was significant before ballooning.
Before ballooning, yeah.
Yeah.
It's already significant before.
I mean, after doing all that,
After doing, you're going to do physiology again?
if you do post-PCI IFR, you would have a picture of a diffuse disease.
Answer this
So-
question.
Yeah. Actually, I agree with you 100%. I would leave this because if you look to this very angle in this very view, you find it actually 90 degree. So I love the DK crush in left main intervention, but not in this case, I believe. I would simply do it if there is any dissection or so with a tap. Here is the final result with the IVUS. Oh, I'm sorry. Just
1 minute.
2 minutes. No dissection in the CX ostium. Actually, good area. Perfectly opposed and expanded stent, huge stent in the huge left main. Also, I just checked for any deformation in the stent by stent booth, and also checked by physiology, which is now very acceptable. I know that there are many caveats about this type of FFR, but anyway, 6 months later, actually, after the patient was very good, jogging regularly, he had angina again while jogging, and as you see, the CX is again the problem, the usual problem. Tight lesion in the osseous CX, perfect result in the LED. Just 1 minute, I'll have a couple of slides. I thought I would make it simple here, so I just treated with a DCB, 3.5 to 30, without any kissing or just taking it with a DCB. The patient now for 2 years is doing great, actually. So that's his final result after the DCB. That was 2 years ago. So my main points is that left main PCI can be greatly optimized, as you all know, and facilitated as well by the use of intravascular imaging and physiology, which can improve both the acute and long-term outcomes. The Achilles heel of left main stenting is the CX ostium. Whether the use of the DCB to optimize the CX ostium after crossover in the index procedure will try to decrease the problem of the CX, this actually remains to be determined.
Okay,
Thank you.
thank you very much.